might look at imaging and the role of imaging in clinical decision making, diagnosis and clinical decision making.
Yeah, what do you think? Should we use ultrasound with Doppler? Should we use MRI? Should we use UTC? Or should we combine them all? What's your opinions?
Could you introduce yourself before you speak so that people know whose opinions they are?
At meetings again, I think it depends on cost. It's a big thing. So again, you know, with patients in private practice, I work in a private practice setting, and you know, you could be asking the patient to spend thousands of pounds on imaging techniques and consider what's it going to add to your management and treatment of that patient. So I think cost is a factor, definitely.
Yeah. So cost is one factor. Other opinions here?
We seem to be seeing this, Christopher again, we seem to be seeing this huge trend towards imaging, and it seems a little bit like boys with toys to me. What we need to concentrate on is validating the use of imaging, not just in terms of does it correlate well with surgical findings, or does ultrasound correlate with MRI, but by including these modalities in the treatment pathway, do we get better outcomes? And we don't seem to be focusing on that.
Can we have some contribution from this side of the room? At the moment you're not coming first.
Derek Griffin, University of Limerick in Ireland. Just want to bring the discussion back to Professor Carr's earlier presentation on central sensitization and looking at positive expectations, having a possible placebo response. If we go down the line of imaging people as we're looking at their response to loading, are we convincing the central nervous system that this is a dangerous activity, that we're actually doing the opposite, that by monitoring these players we can induce a nocebo effect, where we actually get them to be quite vigilant in what they're doing in their loading response. So considering this is a pain problem and looking at pain as an output of the central nervous system, how do you think how we can balance using this imaging in a positive way without creating these negative expectations?
So I guess the consensus that I've got to date is that most people think imaging is not necessarily positive in terms of management, and maybe negative in terms of affecting the person's understanding and ability to manage their condition. Would that be a reasonable summary? Correct.
May I then throw in one thing? What about the legal aspect? If you treat an Achilles tendon on an athlete with eccentrics and you have no previous scan and that tendon ruptures, maybe you have treated a cartilage rupture with heavy loaded eccentrics. Similarly, if you have this normal tendon that you treat with 200 kilos eccentrics and you end up finding that the tendon was normal but it had a full thickness cartilage defect in the knee, would there be any legal problems, you think, if there was no scanning before treatment? That one opinion.
So Patrick Wheeler, Leicester Hospital, Southwark University. I think that's a very good point. I think we need to talk about, are we using imaging to diagnose an injury or to rule something out? And the two are subtly different. That's clinical medicine. I think you're right, there's a legal or medical legal issue if we are missing a diagnosis. But also no one's actually talked about the positive effect of a relatively normal scan on that patient. We talked earlier about placebo effect. If we could put an ultrasound on someone and say, actually, you know what, structurally your tendon isn't too bad. Because all too often patients are terrified that they've got something horrendously wrong structurally. And there's always a combination of structural diagnosis, function, and thirdly, pain. If we said that structurally things are okay, this isn't about to snap, there's a huge positive message there to give to patients.
Sam Rosengarten, University of Melbourne. Yeah, it's exactly the point I was about to make. We often have patients, especially coming back from a rupture repair, who will get to a point where they'll be limited by pain and apprehension that something bad is going to happen if they continue to progress in their rehab, and by scanning them and reassuring them that the healing process is solid and that the quality of the tendon is good. You can support them to load heavier and more rapidly and be more aggressive without being so worried about the pain.
Perhaps one more comment on imaging and we might move on.
Sure, Docking. I don't think we can indiscriminately scan every patient. I think there's certain cases in differential diagnosis that, say for example, good research on Håkan with plantaris. If we don't know if there's an invaginated plantaris or a plantaris nearby, and we don't consider that compression from the tendon, they're not going to do well. So understand, and the same goes with sheath. Don't know that there's a sheath irritation, and we continue them to go through the range. They won't do well. So in those cases, it is beneficial, and completely improved the last two that said that, and that's what I think the research that we talked about today, yesterday. If you can say, yes, there's a big area of disorganisation, but you've still got enough aligned physical structure, that is a powerful message in how we use it. Yes, go, yeah, there's disorganisation, we consider that, but there might have been an adaptation of the modelling to allow that.